Thank you, Dr. Vanti, for involving me in this course. So I'll just talk about surface ablation. There's really not much to show in the video, so I'll just show you a few slides and a few videos as well. So I think surface ablation is the oldest form of corneal ablative refractive surgery, and it's actually probably the safest corneal refractive surgery as well. So why should one not be doing LASIK or SMILE is because these are the possible complications which we know about, flap-related problems like buttonholes, pre-caps, ingrowth. Ectasia is also more common whenever you make a flap or a cap, diffuse lamellar keratitis, possible traumatic damage to the flap. But it's not like surface ablation is not without its complications. We know that sometimes, very rarely, 2-3% of patients, we could develop haze. You can have post-operative discomfort, pain, and of course regression is a known problem with surface ablation. So traditionally, we've been performing surface ablation as a PRK, in which you either scrape off the epithelium using some sort of a blade or any other brush, or you could use alcohol to loosen the epithelium and remove it. If you make a flap of the epithelium and then just put it back, that is called LASIK, as we know. Earlier, we were using epikeratomes to perform epi-LASIK, but that's pretty much been given up now. So the main bugbear of surface ablation is postoperative pain, and some of the measures used to reduce the postoperative pain are, one is prepare the patient for the pain. So if you tell them that they'll have pain, they're often quite okay with it. If you don't tell them about it, then they'll make your life miserable. So you tell them more, then they'll be okay. I always tell my patients, you're going to remember me today, so we'll talk about it tomorrow. And usually they're okay with it. You just have to tell them. They know what they're going to deal with. And of course, if they're very fussy patients, I often give them the bottle of proparacaine to the relative, saying that if it goes out of control, you can use 1 or 2 drops and then return the bottle to me tomorrow. It's really on the first day that they need it. And of course, use topical oral NSAIDs liberally. We even use tramadol for severe pain. Intraoperatively, chilled BSS has been shown to reduce the postoperative pain, and bandage contact lenses using the right fit. And also, there's been a study from Narayan Netralaya group showing that bandage contact lens, which has been pre-soaked with preservative-free Nepafenac, also has significantly reduced the postoperative pain. So I don't have any experience with that, but I know a lot of people are using that. So that's another thing which can be explored, but you have to make sure that there's no contamination, etc. So transepithelial PRK is an advancement of the surface ablation, in which the ablation of the epithelium is immediately followed by the stromal ablation. And main advantage is that the epithelial defect is smaller because it's exactly the size of the ablation zone, and there's no gap between the epithelial ablation and the stromal ablation, so there's no time for the cornea to dry up. And third is because the edges are made by the laser, the chances of erosions at the edges are lesser. So overall, it gives better outcomes and lesser postoperative discomfort as well. PRK haze is a phenomenon that occurs mostly in the setting of higher myopic ablations and may occur following any surface ablation. Newer technologies have reduced the incidence of haze. So I use the Schwinn machine. So they use something called a smart surf ablation, some sort of a kind of a software modification in which the bed is left very smooth after the ablation. And for some reason, that seems to have also reduced the haze. And even postoperative vision, actually, the wow factor that you get with this is a lot better than we used to earlier get with the traditional transepithelial or even PRK. So that's what the haze looks like on the OCT. And typically, the risk factors are exposure to UV ray light, higher ablation depth, and astigmatic ablations, or patients who've not been using their postoperative steroid drops properly. One thing which has really helped to reduce the amount of haze postoperatively is the use of mitomycin C, and I think there's no doubt that it really helps. I'll just skip these slides. So since this is a vast, I'll show you some videos. So it's really nothing. You scrape off the epithelium and then you ablate. So in traditional PRK, you would remove the epithelium manually and then ablate. So you can see you have to end up with a larger epithelial defect than your ablation zone. And the edges sometimes are not perfectly smooth, and you can have little epithelial tags, and sometimes you can get erosions in that place. Whereas in transepithelial PRK, you're essentially ablating exactly the to the size of the ablation zone. When you're ablating the epithelium, the spots are bluish in color, and when you're ablating the stroma, they are reddish in color. So that's how you know when you've crossed over from epithelium to stroma. So this is the Schwinn platform has this smart surf, which gives a smoother bed and gives quick visual improvement and quicker epithelial healing and better post-operative comfort. So why should one be using transepithelial PRK? Basically, shorter procedure time, smaller epithelial defects, faster epithelial healing, and comparable results as traditional surface ablation. And epithelium is the best masking agent. So especially if you've got an irregular cornea, some sort of a scar, or post-keratoplasty eyes, etc., I think those eyes, especially, it has a very important role to play. So I'll just... so this is just showing that the epithelium is bluish, followed by the stromal ablation, which shows reddish spots. And it's when you're applying mitomycin, I think it's important to have the sponge just appropriately wet. If it's too dry, then it won't really have the desired effect. And especially if you've got a astigmatic cornea where the ablation is more in the peripheral part of the cornea, make sure that the area where you're ablated is covered by the mitomycin C. So specific indications where I think trans-PRK is useful is superficial scars, irregular corneas, post-graft, post-keratoplasty, and patients that have had prior refractive surgery, and of course in keratoconic eyes when you're combining with a cross-linking procedure. So just a few cases. This is patient post-LASIK, post-keratoplasty. You can see the change in topography, and again post-DALC, irregular astigmatism, topo-guided ablation. So many of these cases, irregular corneas, I think especially it has a good role to play. And in these cases, when you're using mitomycin C, you should use at least for a minute. I think I'll end here. And
yeah.
Thank you.
Thanks, Rishi. I think as Dr. Fogler is setting up, I'm going to have a couple of questions for you here. Something which everybody wants to know when you're doing PRKs. What's your take on the time you would apply mitomycin C, when and how much?
So I typically use 10 seconds per diopter, and
is it for lower corrections or corrections beyond 6?
No, I use
for
it
all
for
corrections?
Yeah, for all corrections I use,
okay.
yeah, even if I'm doing 1 or 2 diopters.
So 10 seconds for per dioptric correction is what you use.
And for repeat ablations, minimum of 60 seconds.
And do you really incorporate epithelial scanning maps in your PRKs?
Yes, I think that's a very important point.
So that's something which has changed.
So you must look at your epithelial thickness maps, and especially when you're doing, say, enhancement, surface enhancement for a post-LASIK eye, which has been done long ago, you may have even 70 microns epithelium in the center. So
that's not a norm you would apply for a routine, for a primary one, but if you're doing it for all these more than routine scenarios, you would probably look at the mapping.
Yes, you have to then adjust the epithelial ablation accordingly. And then do it,
And one last is, what do you think would be the role of losartan in post-ablation hazes?
I think it's very interesting, but we don't have access to it. So
we're probably looking for more results in...
The question is the number needed to treat. We'll have to think about giving it to every case then if you want to use it prophylactically, or you use it when you get a haze only then.
Probably our understanding is evolving, and we'll get to know more in future. Thanks so much, Rishi.
Just one point, Rishi, in the sense that you have to understand that when we do laser ablation for PRK or any refractive surgery, we make the cornea flatter. And if you go with your conventional contact lenses, for that cornea, that contact lens becomes a tight fit. So use a bandage contact lens with a slightly flatter curvature. Otherwise, you post PRK and then you realize that on the 3rd or 4th day when you're removing the lens has a very stuck-on tight appearance, and that's what makes the patient uncomfortable. And when you remove it also, sometimes you'll have some epithelium come off with it. So
I think that's
you should have a lens that moves.
So
quick comment on losartan, because you mentioned it.
Mic, please. Can we have the mic? I think the session is being recorded,
Yeah, there's the mics there.
turn on now? Yeah. So a quick comment on losartan because it brought up, and especially in PRK. And we all know that the structural basis of haze in PRK
Mike.
is myofibroblasts and also the extracellular matrix that's deranged. I don't think there is, and that's a terminally differentiated cell, a myofibroblast. So I have no idea how the mechanism, based on what I know about losartan, how it can de-differentiate myofibroblast to a transparent cell, which would be fibroblast or keratocyte. So I don't know whether, I don't know, mechanistically it doesn't make too much sense. But as you said, it's evolved.
There's a lot of talk going on about it.
I believe it causes apoptosis of the myofibroblast.
Mitomycin does.
Okay.
Yeah.
So when you have it works, you know, mitomycin.
Yes.
That's classic
Yes,
for
yes,
apoptosis.
yes. Okay. Thank you, Dr. Sandeep and Rishi.